Hi, my name is Joel Chavez, and today I'm going to be teaching you guys about Guillain-Barre syndrome. So here are our objectives for today. Explain the anatomic alterations of the lungs associated with Guillain-Barre syndrome, as well as the cardiopulmonary manifestations, general management of Guillain-Barre syndrome, as well as clinical findings that you might encounter. So what is Guillain-Barre syndrome? So first, it is pronounced Guillain-Barre, and it is an autoimmune disorder that results in a flaccid paralysis of the skeletal muscles and loss of muscle reflexes. In many severe cases, this can lead to paralysis of the diaphragm, which leads to ventilatory support and as well as mechanical ventilation. So signs and symptoms. So the exact cause of Guillain-Barre is not known, but it is known that it is often preceded by an infectious illness such as a respiratory illness or the stomach flu. In most cases, Campylobacter jejuni and cytomegalovirus are the identified cause of the infection. So clinically, people who have Guillain-Barre syndrome, around 60% of them, Campylobacter jejuni is the identified cause. And another note, Campylobacter jejuni is most often associated with with food poisoning. So you might have encountered it once or twice before. Guillain-Barre syndrome often begins with a tingling and weakness starting at your feet and legs and quickly moving upwards to your upper body and arms. So commonly known as ascending paralysis. And the sensation would eventually spread and it could paralyze your whole body. So what are other signs and symptoms? So a prickling, pins and needles sensation in your fingers, toes, ankles, or your wrist is what is most commonly described by patients. Weakness that spreads to your upper body, so again, that ascending paralysis. Unsteady walking or inability to walk or climb stairs. Difficulty with eye and facial movements, including speaking, chewing, or swallowing in severe cases, or once your Guillain-Barre syndrome kind of reaches its peak. Severe pain that may feel achy or cramped-like and may worsen at night. Difficulty with bladder control or bowel functions. So once the paralysis kind of again reaches its peak, you might lose control of your bowels and the ability to urinate or move your bowels whenever you needed to. Rapid heart rate, lower high blood pressure, and difficulty breathing. So it is important to note that when having a patient with Guillain-Barre, you want to kind of sympathize with them and kind of try to understand what they're going through. You wouldn't expect a person that's paralyzed or is becoming paralyzed to be the ideal patient, and you kind of just want to sympathize with them and try to understand what they're going through, and try to help them out with that. A good way to do that is to get family involved in the care of the patient. I had a patient who was affected by Guillain-Barre syndrome, and he had it for a couple of weeks now, and he was really sad. It looked like he was just really sad. He wouldn't want to cooperate, things like that. But as soon as the nurse would show him a picture of his niece, he would be this completely different person and kind of light up, and it really improved his cooperation with us and what we were there to do. So getting the family involved, it can go really a long way in trying to help your patients. So what exactly happens in Guillain-Barre syndrome? So because the exact cause of Guillain-Barre syndrome is not known, what we do know is that it is an immune response to foreign antigens that attack the nerve tissues. So hence why it is known as an autoimmune disorder. The acute inflammatory demyelinating radiculopathy, or AIDP, is thought to be caused by the immunologic attack that results in nerve demyelination and inflammation. So the myelin sheath is kind of what conducts those nerve impulses to our muscles and like our reflexes. So what happens with Guillain-Barré syndrome is the lymphocytes and macrophages attack that myelin sheath and kind of start stripping it off. So when you get a nerve impulse, it's not really conducting as fast, or not even, maybe not, it's not even reaching the muscle fiber. So that's why you start losing the ability to move your muscles and eventually lead to paralysis. So here we have a nice diagram of what exactly happens in Guillain-Barré syndrome. So here we have our muscle fiber. We have our dendrite here, and the L here is for lymphocytes, the M is for macrophages, and here we have a macrophage attacking the myelin sheath, and kind of, if you see it, you can kind of see it stripping it off. This is what a normal, healthy myelin sheath would look like. So as you can see, the dendrite here would be sending those nerve impulses to your muscle fiber, but because the macrophages and lymphocytes are attacking that myelin sheath, those nerve impulses will not be conducted all the way down. So you will lose the ability to move your muscles as well as like your reflexes. And here we have a atelectic lung unit. So what are the pathological structural changes of the lungs? So the major pathological structural changes of the lungs associated with poorly managed Guillain-Barré include mucus accumulation. So the patient cannot cough, they can't clear their own mucus, so that leads to an accumulation, which again will lead to airway obstruction because there's no way to clear that mucus, alveolar consolidation, and eventually atelectasis. If you can't breathe in deeply enough, those alveoli are going to want to tend to collapse if you're not stretching out your lungs adequately. It is also important to note that on a chest x-ray, a person with Guillain-Barré syndrome he or she might have a normal chest x-ray, because it's not really a lung problem that with Guillain-Barré syndrome, it's a nerve problem. So mostly these people will have normal looking lungs, maybe some atelectasis if they've had it for a while and aren't getting the proper therapy for it. So etiology and epidemiology. So Guillain-Barré syndrome occurs in 1 in 100,000 people. It's equally in men and women. Usually the older generation people are mostly affected, so greater than 50. And it is 50 to 60% more common in whites than in blacks. And clinical presentation. So we have symmetric muscle weakness in the distal extremities, accompanied by paresthesia or dysesthesias. Paresthesia is the tingling, burning, and shock-like sensations, while dysesthesias is an unpleasant or abnormal sense of touch, and that's usually what most people claim to have who have had Guillain-Barré syndrome. We have pain and numbness. We have the muscle paralysis that spreads upwards to your arms, trunk, and your face. This can take anywhere from one to several days, and the muscle paralysis usually peaks in about a couple of weeks. After the paralysis reaches its peak, it usually remains with the patient for a few days to weeks, rare cases even months. Improvements begin spontaneously, so it seems kind of like out of nowhere that people start recovering from Guillain-Barré syndrome. And in 10 to 20% of patients will have permanent residual neurological deficits, but about 90% of patients will fully recover. It's also something to note that when a patient starts to recover from Guillain-Barré syndrome, usually before the patient's even off the ventilator. So physical therapists moving the arms and legs usually begins way before the patient even shows any symptoms of getting better. Also, Guillain-Barré syndrome does have an excellent prognosis, but it might take up to several years for a patient to fully recover. But Guillain-Barré syndrome is not, it doesn't have a high incidence of mortality just because many people do recover from Guillain-Barré syndrome. So diagnosis. So like I said, when diagnosed early, people with Guillain-Barré syndrome have an excellent prognosis. The diagnosis is usually based off of clinical findings as well as cerebral spinal fluid findings, EMGs and NCS results. Your cerebral fluid findings usually reveal elevated protein levels, while your EMG and NCS results will typically show evidence of polyneuropathy with demyelination occurring. So again, that stripping of the myelin sheath that is kind of the hallmark of Guillain-Barré syndrome. Other diagnostic studies. So PFTs are usually warranted, and they kind of monitor the patient's respiratory status as the disease progresses through them. An FVC of less than 20, a MIP less than 30, MEP of less than 40, CO2 greater than 45. So we have like hypercarbia, pH lower than 7.3. So like acidosis are usually found and can tell you if your patient is kind of worsening or improving. And if these numbers kind of start going down, or in the CO2's case start going up, then these patients are most likely going to require some sort of ventilatory support, maybe even a trach, if there is no signs of improvement and the physician thinks it's going to take a while for them to recover. So some data that can be attained at the bedside. So we have our respiratory rate can vary with the degree of muscle paralysis. So early on in the disease process, the respiratory rate might not really be affected, but as the disease starts progressing, then the respiratory rate might start to fall. We have apnea in severe cases if that happens, which then would be like an indicator for ventilatory support. Anxiety. I can't really imagine how it would feel like having your whole body start to kind of, attack itself and paralyze while you know it's happening to you and you know that there's nothing that you can really do about it. It must be awful for them. So again, that goes with kind of sympathizing with your patients, kind of understanding what they're going through, and just try to put yourself in their shoes and see how you would feel if something like this were to happen to you. Breath sounds, again, with depending on the degree of the progression of the Guillain-Barré syndrome. So we might start having some diminished breath sounds if patients aren't able to inhale and exhale deeply. They're not moving a large amount of air. We have crackles as well. So once that mucus starts accumulating or the fluid starts accumulating, not properly managed, these are what you would normally hear. So what is the management of Guillain-Barré? So the primary management of Guillain-Barré syndrome is it's aimed at stabilizing the patient's vital signs as well as providing that ventilatory support for them. The real primary treatments of Guillain-Barré are plasmapheresis and intravenous immune globulin. So plasmapheresis, you have that exchange, or it's also known as plasma exchange. So you start removing the patient's plasma that he or she has and try to exchange it for healthier, normal plasma, try to get rid of those antibodies and whatnot that are attacking the patient. The intravenous immune globulin is also used, and it has been shown, and it's shown clinically that it might be even a bit better than plasmapheresis, but either way, they're both effective, and they've been shown to decrease mortality in patients. It kind of helps the patients get through their disease process quicker, and can lead them to get better soon. other things that go along with like general management. So the patient with Guillain-Barré syndrome, he or she might start to drool, have an increase in saliva. So regular suctioning, listening for fluid and see if the patient needs suctioning. These patients are going to be bedbound, of course, so frequent turnings to avoid pressure ulcers and skin breakdown is going to be warranted as well. But so basically, support your patient. Try to get them through their disease process, and hopefully they'll start getting better quicker. So here are our respiratory treatment protocols. So us as RTs are gonna, these are the things that we are gonna be focused on. So of course we have oxygen therapy. It's able to treat hypoxemia, decrease the work of breathing, decrease myocardial work. So again, that goes with supporting your patient. We have bronchial hygiene therapy protocol. So try to get rid of those that mucus accumulation that happens with Guillain-Barré syndrome when people are not able to clear their own mucus. Lung expansion. So because these patients are not going to be able to work out their lungs, we're gonna have to do that for them, help them do that. So of course that's warranted. Mechanical ventilation. When the disease kind of hits its peak and the diaphragm starts getting paralyzed, these patients are not going to be able to breathe on their own. So we're going to try to support that ventilation and oxygenation. So we're going to basically help them. We're going to help breathe for them while the ventilator is. So we're just there to support their gas exchange. And what happened in 1976? So this is kind of a history lesson. So in 1976, over 40 million adults were vaccinated against swine flu. Then what had happened was over 500 new cases of Guillain-Barré syndrome were reported. That resulted in 25 deaths. So the Institute of Medicine, or the IOM, conducted a review and concluded that those people that received the 1976 swine flu vaccine had an increased risk for developing Guillain-Barré syndrome. Scientists have many theories on this, on why this happened, but today there is no reason for this association. So what does that mean for us? So because this happened a long time ago in 1976, we're going to start seeing an increase in age in these people. So these people are becoming older. So we might start seeing an increase in Guillain-Barré syndrome diagnoses. So be on the lookout for that. So here are our questions. Is Guillain-Barré syndrome hereditary? And the answer is no. So Guillain-Barré syndrome is not hereditary. You can't catch it from anyone else. Parents can't give it to their kids, and they can't give it to their kids. So we know that it is an autoimmune disorder. It kind of just affects people differently at different, stages in their lives. So older patients, but so far there is no evidence to prove that you can pass it on to anyone else. A patient is affected with Campylobacter jejuni, which disorder would the respiratory therapist be on alert for? So here are our options: myasthenia gravis, Lambert-Eaton, and amyotrophic lateral sclerosis, and Guillain-Barré syndrome. And of course, the answer would be Guillain-Barré syndrome. As I said, Campylobacter jejuni is around 60% of the time identified as the causative agent for people developing Guillain-Barré syndrome. The other three options don't even really make sense. They're not, because they don't really happen with like infections. A patient is experiencing numbness and prickling sensation that started at the toes and progressively moved towards their legs. So what can this be classified as? Your options: descending or ascending. And hopefully by now you all know that Guillain-Barré syndrome is a ascending disease, meaning it starts from the lower extremities and starts working up. So that's why, hence, it is known as a ascending paralysis. Which age group is most likely to be affected by Guillain-Barré syndrome? So here are options: 20 to 30-year-olds, younger than 20-year-olds, 40 to 50-year-olds, and greater than 50-year-olds. And by now, you should know that the older population is more likely to be affected. Scientists don't really know why the older generation is most likely to be affected. Could be due to comorbidities. Could be due to kind of a decrease in your immune response. You wouldn't expect a 55-year-old to have the same, immune response that a younger, like 20-year-old person would have. And can Guillain-Barré syndrome be cured? And hopefully you know that. No, to date there is no cure for Guillain-Barré syndrome. It can be managed, and patients can have an excellent prognosis and can return to life with relatively no consequences. But to date, there is no cure for Guillain-Barré syndrome. There's only management. Here we have our references that I used. So that was Guillain-Barré syndrome, and hope you all learned something. Thank you for your time.